A Diopsis-sponsored webinar, originally recorded December 9th, 2014. Hello everyone, and welcome to the webinar to treat or not to treat new methods for diagnostic testing with Dr. Lawrence Gindra.
Everyone, thank you for attending this webinar. I'd like to give you a very brief background of why I'm interested in this. 35 years ago when I was a medical student, I started doing research in this field. I discovered that this type of testing could discover changes in visual function well in advance of many other then current modalities. 35 years later, I feel it is still the case. It is no accident that in the laboratory I was privileged to work, one individual was awarded a Nobel Prize and two individuals were awarded MacArthur Prizes for genius. This is really very rigorous vision science, and I am pleased to be able to discuss it with you. Many of you have seen this slide. Just starting out very quickly, this is a slide of the visual system starting from the eye to the retina, through the optic chiasm, the optic radiations, to the visual cortex. In the function of the visual system, we start with a photon of light. We go through the trilaminar structure of the retinal neurons, the photoreceptor, the bipolar cell, the ganglion cell, which then ultimately ends in the visual cortex. Why are visual diagnostic tests important? Well, because they can tell us in terms of earlier diagnosis and in better management, information that we can't get from other tests for diseases like glaucoma, multiple sclerosis, optic neuropathies, trauma, amblyopia, etc. So let's start at the beginning with some psychophysical testing. Visual acuity is a psychophysical test. You're asking an observer to determine a threshold. And in this case, it is of high contrast optotypes, 100% contrast, black against white, with decreasing orders of spatial frequency or higher orders of resolution. A visual field test is also a psychophysical test. You're determining the threshold of a certain set of photoreceptors, ganglion cells in the visual field. The observer has to determine, do I see the stimulus or not? And that uses, with these kind of automated static perimetry, it uses an up-down transform rule with a two alternative force choice testing, either yes or no. Again, that is a psychophysical test. Contrast sensitivity is the highest order of psychophysical tests, and contrast sensitivity will examine spatial frequency against the reciprocal of contrast sensitivity, which is contrast threshold, providing a two-dimensional function. You can also do a temporal contrast sensitivity function or a three-dimensional spatial temporal contrast sensitivity surface. Where psychophysical testing is subjective, electrophysiological testing is objective. And very different varieties of electrophysiological testing include the visual evoked potential, which is either transient or steady state, multifocal evoked potential, the ERG, multifocal ERG, the pattern ERG, or the electrooculogram. What factors can affect visual electrophysiological results? Meaning a patient doesn't take part in the stimulus, they don't indicate yes or no, they don't indicate left or right, they don't indicate on or off. But there are certain physical factors that can affect the results. Refractive errors can. There was a paper published by Sam Sokol about 35 years ago on this. Intraocular pressure can. We all know that glaucoma is preferentially affected in the magnocellular pathway, and that can affect electrophysiological results. Diabetes can affect electrophysiological results. Patients' attention can. Someone can close their eyes. Someone can look away, meaning that the stimulus is not presented on the fovea. And the technique and experience of the observer can affect the results. What is the visual evoked potential? It is a time-locked electrical signal registered at the occipital cortex in response to a visual stimulus. This is an example right here of one of the old-fashioned transient VEPs. For those of you who remember this kind of electrophysiology, there's a P100, that's a sentinel point, and then there's the negative deflections. So, visual evoked potential, three things. First, visual. The patient has to observe a visual stimulus. They have to be attending and they have to be foveating. The response is evoked at the retina where the signal generates electrical activity. The sensors on the scalp measure the electrical activity that is present on top of the ongoing EEG due to this signal registered at the occipital or visual cortex. The VEP is an objective measure of the function of the entire visual system. From the retina to the cortex, we can objectively measure visual function. Subjective responses from the patient, either verbal, gesturing, pushing buttons, is and are not required. In the old-fashioned tests, there were limitations. The test time was approximately 45 minutes per test. It required highly trained and experienced operators, and generally it was limited to large academic medical centers. Currently, the patient test time for a run is about 1 minute, and that's very simple. One word, computers. The work that I did in the early 80s, excuse me, if you go and you look at computer memory, computer processing speed, computer data transmission have all increased by about 1 million-fold. That is why this is now a clinically useful test. The science, when it was first invented in the 1950s, and the research, when it was done in the 70s and 80s, haven't changed. They've gotten better. These all existed. Making it a clinically useful test is due to high-speed computers, the software, and the sweep algorithms. The technician then administers, so the patient test time is approximately 1 minute. The technician administers an automated test protocol using state-of-the-art sweep technique. And for the clinician, graphical reports are produced which allow quantitation of therapeutic results and allow for visual documentation for monitoring the disease. VEP stimulus is generally presented in what is called contrast reversal. The old-fashioned transient VEPs used time domain. The x-axis was in milliseconds, like you saw with the P100. The modern steady-state visual evoked potential are frequency or Fourier domain. And many of you know about this through the OCT and other methods of analyzing retinal fine structure using spectral or frequency domain analysis. To look at contrast reversal, we start with this screen. Pattern is presented, and you see here it is white, here it is black, and then it is reversed, and the checkerboard where black is white and white is black reverses itself. So the VEP components, and here's the P100. This is an old-fashioned transient VEP. Amplitude is related to the anatomy or the form. It usually translates to the number of axons conducting along the visual pathway, and it's measured here in microvolts. Latency is the physiology or the function. It usually translates to the function of axons conducting in the visual pathway, and it is measured in milliseconds. A VEP report is generated. Here you see the amplitude and the latency and some parameters which we will go into. So first on top we have the waveform. This is the the steady state VEP. These are the raw data. So here's 100 milliseconds, here's the P100, here's 100 milliseconds, here's the P100. Now looking at this, the dark waveform is the high contrast or parvocellular projecting system waveform, and the light contrast is the low contrast. So these are two different visual pathways with just a bunch of squiggly lines. This is what people used to do research on. They would look at the height of the P100, they would look at if there was a delay, and they would try to make determinations. Not very easy, as you can see. Now when you enter with the mathematics, it becomes a lot easier. So here we have a sum of that waveform looking at the principal components. In the amplitude, the magnocellular system, the parvocellular system, and then the latency of both the low contrast or magnocellular system and the high contrast or parvocellular system. And we can look at the absolute numbers of both amplitude and latency, look at the differences, and through the program that is presented with this machine, it can tell you if green, if it's in the normal range, yellow, if it's in a suspect area, or red, if it's abnormal. This is the reliability index. These kind of numbers are very similar to statistics that people who are familiar with the automated static perimetry will notice. So what are the applications of VEP? It was developed objectively to measure the function of the entire visual pathway. It provides quantitative information to support the clinician in the interpretation and diagnosis of vision defects. It objectively documents the results of clinical interventions. That offers the clinician a means to track disease progression and to provide data to support medical decision making. And it takes the subjectiveness out of the test. So patients with either language or communication difficulties are able to take this test. I do not test children, but there are pediatric ophthalmologists who use this test in pre-verbal or non-verbal infants and children. The other visual electrophysiological, major visual electrophysiological test is the pattern electroretinogram, or PERG. It is an electrical signal registered at the lower lid in response to a visual stimulus. When you look at the raw data, you usually see these three parts of a sine wave in the data. It is indicative of the electrical activity of the retinal ganglion cells en masse or in total. So the PERG is the electrical signal that's generated at the eye due to a pattern stimulation of the retina. The time is measured in milliseconds. The amplitude is measured in microvolts. The eye is stimulated by a checkerboard pattern which elicits a retinal ganglion cell response. This is the PERG. It's an accurate and objective indicator of ganglion cell as well as macular function, and it can detect retinal dysfunction before structural tests do. So we have the pattern that's contrast reversing itself. This is a square wave checkerboard pattern. It's presented to the visual system at the eye. It's recorded by the sensors. A waveform is produced, and it all comes from these electrodes. There is a ground electrode and an active electrode. When I started in this field in the 80s, there were very complicated gold wire electrodes on very large plastic scleral contact lenses. Almost always resulted in some kind of superficial punctate keratopathy or even a corneal abrasion to the patient. Here it's put right under the eyelid, and it's quite pleasant for the patient compared to the other way. Main indications for pattern electroretinogram are glaucoma and maculopathy. So with the pattern electroretinogram, there are concentric fields at 24 and 16 degrees. So that signal that you saw then will elicit this waveform over here. This is the smaller field, which will elicit a smaller waveform. The concentric fields are a steady state stimulus at 15 cycles per second, or 15 hertz. Best corrected visual acuity is refracted for 2 feet. The right eye then the left eye is tested at high contrast at 24 degrees and at high contrast at 16 degrees. It is an objective study of focal disease, drug toxicity, diabetic macular edema, age-related macular degeneration. Now, we can do the pattern electroretinogram not with concentric visual fields, but with contrast sensitivity using high and low contrast. There's a square wave grating, elicits the waveform, high contrast and now low contrast. It is a steady state stimulus, again at 15 hertz, best corrected visual acuity at 2 feet. The right eye, then the left eye is tested at high contrast first and at low contrast second. The contrast sensitivity is a study of diffuse, pardon that. We seem to have gone backwards. Let me catch that. It's a study of diffuse disease, either glaucoma or diabetic retinopathy. Let's look at the PERG report. You see the waveform and you see some key numbers. Let's go through them. So the waveform. This is a very good test. 3 sine waves, amplitude, time. Right eye, left eye. Signal quality is good in green. Again, this is a breakdown of the frequency components with a P100 spike, as you can see here. These numbers are important. The magnitude, you want at least 1.2 microvolts. This magnitude D is a mathematical interpretation of the value of the signal. You want this number here, the magnitude D, to be at least 50% of this number. So 50% of 2.8 is 1.4. With 2.7, that's a very good signal. 50% of 1.7 is 0.85. 1.68 is a very good signal, so on and so forth. So these 3 numbers are what I look at. I look at the humps in the waveform, I look at the magnitude, and I look at the magnitude D. Obviously, if the signal-to-noise ratio is large or the artifacts are low, that's a very good test. Clinical applications of ERG. Why is it helpful? It was developed objectively to measure retinal function. It provides quantitative information to support the clinician in diagnosis of retinal deficits. It objectively documents clinical intervention, offers a means to track disease progression, and provides data to support medical decision-making. It's effective, objective test to help diagnose maculopathies, age-related macular degeneration, diabetic macular edema. If you have a vision problem of unknown cause, the pattern electroretinogram and the visual evoked potential can differentiate between optic nerve and retinal disorders. Visual pathways are a bifurcated pathway. Magnocellular pathways are the large retinal ganglion cells that project to the magnocells of the lateral geniculate nucleus. They process signals best at low spatial frequency, high temporal frequency, and mesopic conditions. They are an early loss of the magnocellular processing is an early indication of glaucoma. And this physiology supports the anatomy of the landmark paper that Harry Quigley published probably about 30 years ago now on the large retinal ganglion cells being preferentially affected in a disease like glaucoma. The opposite is the parvocellular pathway. High spatial frequency, low temporal frequency, high contrast. That's what you use when you test the Snellen acuity chart. That's what you use when you read. The degradations of parvocellular pathways then clearly would be an early indication of maculopathy. It's in the macula that you have the high resolution. It's in the macula that you have the highest visual acuity. The macula is rich in parvo cells. The periphery is rich in magno cells. So now we have a spectrum. Here it's pretty easy. We know what healthy is. We know what glaucoma is. This part is what gives us trouble in the middle. So what can we do with the visual field? Well, we can determine which patients have glaucoma and which patients are healthy. We all know Harry Quigley's other paper where he found a person can lose 45% of the volume of the optic nerve and still have a normal visual field. So it's late in the disease course when the visual field will start to be affected. We all know that. We all know patients who have very cupped nerves but have normal visual fields. Then when the visual fields start to go, it seems like the disease is progressing rapidly. It's not. We're just catching it at the end. So we have patients who have glaucoma and patients who we can agree are normal. Then along came the visual field is a functional test, and we had the anatomical test, either ocular coherence tomography or scanning laser polarimetry. They took the diagnosis a little more to the left, meaning there were patients that tested healthy with visual fields but had glaucoma, but it couldn't be picked up. So with OCT, we were able to document structural damage earlier, or with scanning laser polarimetry, earlier than visual field. Now we're going to look at the effect of visual electrodiagnostic testing. We can then take patients that would have been passed as normal with OCT and say these patients are affected, meaning that this test is more sensitive in diagnosing glaucoma than these two tests, just as this test was more sensitive than this test. So let's look at some reports from the literature. This was a paper that was written in the 80s when I was doing this research. It was done by the group at the New England Medical Center. Here is Sam Sokol, who I said did the paper on refraction. Bernard Schwartz was a physician who was doing some work, Ann Moskowitz was a great, is still a great vision scientist. She's an optometrist now, and Vern Towle is the first author on this paper. I want to go back for a moment. So in the abstract, I'd like to call attention to what was in yellow. Increased pattern VEP latency was significantly correlated with both the severity and location of visual field defects and the degree and cupping and pallor of the optic disc. This was the first time that this was really quantitated and put down in a peer-reviewed paper. Glaucoma has also been reported to affect the VEP by causing both reductions in amplitude and increases in latency. Under the stimulus condition that was used in this paper, more than half of the eyes with glaucomatous visual field defects had abnormally long VEP latencies. None of the VEPs from normal subjects were abnormally long. About a quarter of the eyes of ocular hypertensive patients also had abnormally long VEP latencies. Now, that means that there were patients who were previously passed off as just ocular hypertensive who, with this test, were shown to really be glaucoma suspects. It should be noted that nearly half of the eyes with the glaucomatous visual field defects generated normal VEPs. And they were justifiably concerned why these patients generated normal VEPs. That's because they were doing the test in photopic conditions and they were really assessing parvocellular function. By reducing the intensity of this stimulus display by as much as 1.5 log units, it caused abnormal VEPs either in latency or in amplitude in more than half of those patients, meaning they were then tapping into the magnocellular pathway, not by affecting spatial frequency or temporal frequency, but just by changing the ambient luminance conditions to preferentially monitor the magnocellular pathway after the parvocellular pathway had extinguished. That finding was of clinical importance because the presence of these abnormally long VEP latencies in some patients with ocular hypertension boded that these patients truly were glaucoma suspects and required even more detailed monitoring. The abnormal prolongation of the latency could reflect subclinical optic nerve lesions which were uncovered with other techniques. That is a very important finding. That finding was not published 3 weeks ago. That's over 30 years old. Let's look at some patients now. Here's a patient that has a normal VEP. We see a good P100, we see amplitude and latency in the green, and we see the raw numbers in the green. This is an abnormal VEP. Here you see the P100 is shifted to the right, meaning the latency is increased. You also see that the amplitude is knocked down a little. So in the right eye here, in both the low contrast and high contrast pathway, the latency is affected. And here you see the values, and this graphical presentation can catch your eye. If you couldn't see it here, it's made manifest over here. So let's look at a case study. The patient who's a glaucoma suspect, 70-year-old white lady, history of elevated intraocular pressures, family history of primary open-angle glaucoma, visual acuity, pupils, angles, all normal. Pressures in the afternoon were over 20. Thin corneas, and not that was taught by Max Forbes and George Spaeth not to use the decimal system. We wrote a paper about how inaccurate this is, but pardon me for using it here. You'll see that the right eye has more cupping than the left. So automated fields were done. There was a slight depression in the inferior Bjerrum area of the right eye, with the eye with the larger cup, and the visual field was without defect in the left. OCT testing, asymmetric cupping, but normal OCT. So now we do the electrophysiologic tests. And here you see in the low contrast pathway how the latency has increased. You may not be able to pick it up by looking at it here, but you see it here. So there's an objective measurement of optic nerve dysfunction that supports the diagnosis of glaucoma in this patient. Treatment with SLT resulted in a decrease in IOP to goal pressure, and the patient was monitored half yearly. So here's a patient who might have been passed off as sort of normal, maybe glaucoma suspect, who now was demonstrated to have physiological loss in the visual pathway that preferentially processes for glaucoma, that was then treated, the pressure was lowered, and their prospect for retaining visual function was greatly enhanced. So here's a patient that was a glaucoma suspect, 45-year-old white man, no history of elevated pressure, no family history of glaucoma, visual acuity, pupils, angles, all within normal limits. Pressures were mid-teens, average corneas, cupping out of proportion to the pressures, larger in the right eye than the left. Normal visual fields, no defects. Abnormal OCT in the right eye, borderline in the left. So we do the test. Low contrast pathway, amplitude and latency in each eye is normal. Objective measurement of optic nerve function by VEP supports the diagnosis just of glaucoma suspect. No treatment was indicated, no SLT was done, the patient is monitored half yearly. Now let's look at some literature of ERG. This is a more recent paper. Patients who are glaucoma suspect, the pattern electroretinogram signal anticipates an equivalent loss of OCT signal by as many as 8 years. That's quite significant because when the OCT came out, they said the OCT would anticipate an equivalent loss of visual field by about 8 years. So using that, it looks like the visual electrodiagnostic testing can anticipate an equivalent loss of visual field signal by as many as 15 years. A decade and a half is a significant amount in patients over 50 and 60 years of age who are suspected of having glaucoma. Let's look at a normal ERG. 3 humps, the numbers all over 1.2, and the magnitude D all greater than 1/2 of the magnitude of the signal. This is, I apologize, there's a typographical error. This is an abnormal ERG. You see the uneven waveform. Here you see in the right eye the amplitude greater than 1.2, but in this test, this is far less than 1/2. Here, it's even worse. The amplitudes are less than 1.2, and this is severely less than 1/2 of this. Let's look at a case study of an ERG patient who's a glaucoma suspect. 65-year-old white woman, no history of elevated intraocular pressure, no family history of glaucoma. Visual acuity and pupils were normal. Pressures were in the high teens. The central corneal thickness was close to average, but there was asymmetric cupping. So the OCT testing was normal in both eyes, but showed asymmetric cupping. However, when we did the ERG testing, it was abnormal. You see how the magnitudes are on the lower side, and the magnitude Ds, how far off they are. This indicates abnormal retinal processing by the ERG. So case 2 is maculopathy. 60-year-old white woman, history of floaters, no family history of macular degeneration. Visual acuities and pupils normal, pressures mid-teens. There's cellophane maculopathy in both eyes and asymmetric cupping. So on the OCT, there was an increase in the internal limiting membrane in both eyes. Visual field testing was normal without defects. The ERG testing was normal in both eyes with normal amplitudes. Here you see how this is a little less than 1.2, but look how, when you look at the magnitude D, this is significantly more than 50%. So here, the magnitude D is all greater than 50%. There are 3 humps. They're not as equivalent. They're not as symmetrical. That's why the mathematics is so important, and you see that over here. Now you can answer, after this lecture, this question. Why would a VEP show a functional change in vision in patients with visual acuity of 20/20ths? Simply because you're testing with the wrong modality. If you test off the fovea with the parvocellular pathway, you might indicate some disease that is affecting the peripheral retina. If you test for glaucoma with the low contrast magnocellular testing, you might indicate visual loss, even though the central fovea, the parvocellular area, does present with 20/20ths visual acuity. I thank you very much for your time and your attention. I thank you for your attendance this evening.
For more information, please contact Diopsys at info@diopsys.com or call 973-244-0622.